So I think the ringleader has escaped. So I would be speaking to you on surgery for von Hippel-Lindau-based angiomas, and where surgical indications are required in relation to these variety of cases which come to us. So as you know that these cases tend to develop angiomas on and off and very erratically. There's no prediction of when the next one would come or which eye it would come, and it also goes to the brain at times. So you need to investigate them from every aspect. And the typical treatment that you do is when you see them, you would laser them. If you see an angioma, the sooner it's lasered, cryoed, in whatever way you can regress it. If it's large, then only laser may not work, and you would need to do an additional cryo of sorts to burn it off. Any sort of way you could regress them is the best, because the longer they remain leaking, they will create a lot of problems, right from exudations, collection on the macular area, to tractional membranes which come up and make it more and more difficult to treat. So these are some of the examples which you see where at different stages of the angiomas, and we have lasered them, and there have been exudate collections which happen. So keep them on a good close follow-up. But once they go on to a stage of a traction, once there is traction coming up, and they tend to have a lot of membranes also which form. So these are the cases that I'll show you a series of cases of angiomas over the years that we've done. So you can see a very thick opacified kind of a vitreous also visible very easily, which is classic of these kind of cases. Also membranes and layers which form, which can be quite thick. So typically, as you would do, remove as much vitreous as possible and explore and remove any traction which is there alongside, and your final aim is to regress them. So here we are going to remove this angioma which is protruding, and before that just diathermizing the vessel so that the bleeding is controlled during this process. So totally diathermizing them and removing them in toto. So gradually exploring all the areas in this patient which are there, which have caused the angiomas to leak. And then you can see that I put perfluorocarbon just to stabilize the posterior pole, so that if suppose there is a bleed which is likely to occur in these cases, keep the pressure high temporarily, and the PFCL would prevent the blood from immediately going to the foveal side, and using that as a base, then you cut off all that area, and which will help eventually regress that tissue, because otherwise there's a whole tractional component which builds up around that area. So this is the post-op picture of that particular case in the first few days that we had taken, and eventually this is after oil removal in this situation, that a full good regression had taken place. So your aim is to make sure that the macula remains flat and good and healthy, and so the vision can be spared. And a lot of these cases are one-eyed, because a lot of them have lost their other eye, and they've not bothered till this eye gets affected, and then it becomes more difficult. So this is a much more aggressive case. As you can see, large angiomas, and also the thick vessels that you see everywhere with lot of exudation coming along. Again, after doing a vitrectomy, put some perfluorocarbon to check how it's behaving, also to remove some of the peripheral attachments, put triamcinolone to help stain, and then diathermize these vessels before tackling the angiomas which are there. Very thin ones you can laser them off, but these thick ones you need to some way take them away with the cutter. But before that you would have to do a good diathermy and make sure the bleeding doesn't happen. So here in this particular one we are doing cryo to help regression, because it's too thick an area. So laser, cryo, everything that is handy can be used, as long as, and make sure that there's no traction which passes. If it's just a lying angioma, you could leave it, but if there's a passing traction, then you would need to do something about those. So here once again you see that uh, at the stage later on that you see these cases inferiorly, there's tissue, there's thick membranes which keep coming up in these cases, and once again we are diathermizing some of the feeder vessels which are there. And also, while you do the actual cutting, the pressure should be momentarily high to 60, so that even if there is a bleed, it will not suddenly ooze out, and give you time to check whether there is a bleed which needs to be controlled for a persistent time, or it's a momentary bleed which goes away. And they always form thick membranes, and yeah, wherever when you reach this stage of tractions, they will have multiple layers of membranes which come up in these cases, and sometimes they extend as subretinal bands, like here I remove one of those from that area. So every level gets affected in these cases. So the best stage is when you see them, when you can just externally laser them, and that's why the rule of screening is very important for this. This is again fiery looking angioma with multiple membranes and traction. You can see infranasally. So the retina is also partly lifted off inferiorly. So once again doing a vitrectomy, and to remove, I also sometimes use these stains which help you see the membranes better, and here you'll see that as we've stained, and we are taking the help of that to identify the plane of this membrane, and gradually trying to pull it off, and how thickly the adhesions are, and you can see how a bleed starts. Suddenly a big vessel there has been ruptured by the peeling, and this is what I talk about, that you need to be very, as soon as you see the first sign of bleed, make sure you have the pressure is raised, and then you can take care of the bleeder in time. Otherwise it will immediately spoil your field, and may also go into the subretinal plane partly, and make things more and more difficult with time. And then once you have it settled, then do cryo laser to these areas. You can see that I'm indenting and making sure a large surface area is ablated with the cryo, because in this laser alone may not work, they're quite thick in nature. So these are some of the examples of how the regressions, and at times the fluid under the macula may take a long time to clear up, even if you've stopped and you need to watch it. Sometimes we also use additional anti-VEGFs, although anti-VEGFs don't have a role on the angioma itself, but sometimes they just help clearing up the fluid faster under the macula in these cases. And this is just one case where it didn't have extensive traction, but this is a young girl, actually 16-year-old, who had bilateral angiomas, and at some point came with this membrane and formed a pseudo hole first, and eventually the traction kept on increasing, and that's when we operated her for this particular eye. The other eye was already a worse eye, and this is the only good eye which she had, and that's why she hesitated surgery for a while. And at this stage, when there was the traction had increased, we operated. So you can see that the macular area has this elevated vessel which is there along with the membrane which has formed. So I'm diathermizing that under a high mag just to see the plane better, and so that it doesn't bleed. We make sure that we cut it at the right plane, and then of course peel this membrane off. And all these adhesions could have connections to the vessels, and they can bleed at times. So remove the membrane carefully. There was a pseudo hole which had converted into a hole by the time we had operated, and you can see a very thin area. Once the traction is gone, the hole is almost pinpoint in nature. So also remove the ILM in from this area, and then the macula flattened well and then regressed well at this stage. So these are some of the examples of this particular condition, which is rare, but in tertiary centers we do see them very often, and importance is to screen, laser, cryo on time so that you don't have to face surgery, because once they go on to the surgical stage, they can take any course, and it's always difficult to manage, and individually each case will have its own equation of how to manage them. So these are a few cases that I wanted to share, and maybe Sangeet, Hemant would would have their own experience with such cases.
Yeah.
Yeah.
So I'd just like to ask one thing is what is your experience on the feeder vessel photocoagulation versus the surgery or
I mean,
retinal?
only as the
Yeah,
treatment.
only
Yes.
as
So
the
before, if there's no surgical, if you are just seeing angiomas, we do that along with, if the size of angioma is small, also do laser on the angioma with the feeder, and or do cryo. So, and then prepare the patient for maybe multiple treatments. So what I do is, for cases which already have some fluid on the fovea, we do laser cryo plus anti-VEGF and call them in 15 days, 20 days, and try to see regression. And sometimes they need a top-up treatment, and then keep a regular 2 to 3 monthly watch, because I've seen that the new tumors have a way of coming anytime. It's not, there's no prediction. If you've sealed something very well, everything is regressed, but in another 2 or 3 months when they come, you may see another small one coming up from somewhere, and it's best to catch them and laser them, even the feeder vessel along.
So,
Actually, what is they say is that best is to, even if you see two tumors, do an FA,
Yeah,
because you'd be surprised that there would be multiple of these small ones which get missed
I
on
agree.
clinical
I
examination.
agree. Yeah, I
So
agree.
that is what we actually don't clinically see, but
Yeah.
on FA they are fairly
Agreed.
evident. I think
These
that's a,
are very good indications for
for
FA,
doing
right?
it.
Yeah.
And doing the feeder vessel, we have also done quite some, and you need to identify, there might be not one feeder vessel, generally they can have multiple feeder vessels.
Multiple also.
So you need to coagulate them specifically, then it does well.
Sure.
I agree with you that once it's not a stage for surgery, then I think laser works very well.
It works well.
Yeah,
Till
it
that
works
time
well.
it works well. So it's only a problem once they develop traction. And in fact, if you might have seen, from Brazil, Andre Mea has shown many surgeries of ligation.
Ligation.
Also.
So you have done any ligation?
No,
I was about to ask you the same
I
thing.
haven't done ligation, but I've seen his work that instead of lasering, they do they ligate with a suture and the feeder vessel, and have had some good results.
I
Also.
think Sangeet has done some. What did you do? It's ligate or you?
no,
remove that?
I do excision
You
only.
re-excise it. Okay.
What I have seen is like if we do during the surgery, sometimes we do feeder vessel coagulation only, or maybe with ligation. I don't know because I've not done. Generally, new feeder vessels they develop from the sides to the tumor.
I was
So
going to
no,
say
sure.
that there
Yeah,
are
so what we have observed is, okay, now you do an FA, you might find two feeder vessels, you coagulate them. Subsequently, on follow-up, you will see again it starts getting
Yeah,
vascular.
yeah, they
That
can.
means there's another feeder vessel which has
Yeah.
developed, which is a very good point
Even
actually.
even with
It
a
does
good
not mean that
laser,
one
yeah.
time you have done it, it closes the matter.
Even with a good laser, after a few months, you may see that reddish
yeah,
hue
yeah,
is
again it's
back
still-
again, and you don't know whether to treat it or to observe it. Sometimes it is.
No, so new feeder vessels come up.
yes,
I agree with
yes,
you.
I
That's a
agree.
very-
I have also seen that new feeder vessels and very resistant to treatment.
The other
Well,
other thing I've seen, Turkish Remzi has used to show videos of endocrio. I don't have an endocrio, but I think that's another great
another
tool for something like this. You can actually go inside and use cryo right over the tumor, and it works.
But that will be how, what, 23 gauge, 20,
Yeah,
20,
small,
that
but
is
they
going
had
to be
access to
wood-
it. I mean, I don't. I've
Nowadays
tried to find out, but there's nothing here. But they have shown that also as one of it.
In one of the cases which I saw, another peripheral tumor after you do vitrectomy, I think is it better to put a belt buckle because that contraction is always a bit there, na?
Yeah,
That's
yeah,
a-
could be. I'm
but that's
sure, because post surgery there will be more
Some
contraction.
contraction
A
that
belt
will
buckle would be useful.